So today the panelists on board are Dr. B.S. Ankit Nehra, who is Consultant Medical Oncologist at HCG Hospital, Jaipur, Dr. Kripa Bajaj, Consultant Medical Oncologist, Hyderabad, Dr. Devendra Paul, who is Consultant Medical Oncologist, American Oncology Institute, Ludhiana, and Dr. Mohit Saxena, who is Consultant Medical Oncology and Hematology, Narayana Super Specialty Hospital, Gurgaon. Over to you, sir, for your panel discussion.
So, sorry for keeping you wait. So, I'll be discussing some practical aspects regarding the metastatic RCC. So, the case that we have is a 76-year-old lady who presented with right flank pain. There is no obvious medical history except the BP is slightly high, and there is history of 20 pack year smoking. Lab results are normal except HB is 11. So this patient underwent radical nephrectomy. It had grade 3 clear cell RCC. Margins were negative. So on a follow-up scan, because of some coughing, a repeat CT scan was done, which showed lung nodules. So the creatinine level was 1.5. You can see from the scan that there was presence of lung nodules. So my question is to Dr. Ankit. So do you think that adjuvant therapy would have been useful for this patient?
Sir, actually, there is still no role of adjuvant therapy except that as trial there is no other than PFS benefit, there is no OS benefit, and that ASCO 2022 also there was a trial which showed that there is no benefit of actually adjuvant therapy as well.
Okay, so any take on Keynote 564? Would you like to give it in some patients? And if yes, then what profile of patients would you would be tempted to give pembrolizumab adjuvant?
So we have that Chinese paper, where
your voice is not audible.
The mortalities within even
maybe Dr. Davinder can take this question.
Yeah, hi, good evening, Rajat. Hi, Rajat, I know the trial data and all those things, but still, I think in practicality, I don't think it will be sufficient. We are convinced enough for this adjuvant treatment in such patients.
Correct. So I don't think that any of us would be comfortable, but any set of patients that you would be tempted, suppose this was T3 N2 disease, then would you be tempted to give adjuvant pembrolizumab?
I
Yes,
think,
sir.
Rajat, in those patients are early progressive, I think. In those who progress early, who have a short PFS, maybe those patients, otherwise it's difficult to say.
So I think for this patient was not a candidate, but unfortunately this patient progressed. So just briefly, the Keynote 564 study, so it was histology confirmed clear cell RCC, and they were randomized to pembrolizumab versus a placebo. The primary endpoint was DFS and the key secondary endpoint was OS. So with a hazard ratio of 0.68, you can see that the DFS even at the end of 24 months, it favored pembrolizumab 77% as compared to 68%. Although we don't have the OS data, but probably in future we'll have data to use it at least in high risk patients. So Dr. Mohit, how would you approach this patient with a lung mets which has progressed around 6 weeks after surgery? What would be patient patient is not symptomatic. Patient is not symptomatic, only mild cough. She's 76 years. And on a routine scan, we did a CT scan and we found a lung nodule. So how would you approach this patient?
As far as I understand, within 6 weeks it is developing. So it is after nephrectomy. And if we forget about the other criteria, means it is falling at least in the intermediate risk category. It is intermediate risk metastatic RCC. That's what I feel. So and the disease burden is low. So for this patient, I would like to go for IO combination, that is Nivo EP.
Okay. So any other thoughts from other panelists? Dr. Kripa?
Yeah, sir. So 76 years old male, like definitely the other panelist will IO combination. That's a right. I mean, it's a worthy option, but IO it's not an easy than managing TK plus IVO. The patient has to like really within short time he got a recurrence. IVO can be considered, but IVO like all of us burnt our fingers with a significant rash as well as diarrhea. I feel IVO plus low dose TK I would prefer than that. If not affordable, then single agent TK I would prefer. Definitely, I'll not observe the patient.
So I hope I'm not missing any panelists. So I have Dr. Ankit, Dr. Davinder, Dr. Mohit, and Dr. Kripa, right?
Yes, sir.
Yes. So Dr. Davinder, would you consider an option of surveillance for this patient? So any patient that you would consider an option of active surveillance?
We can observe those patients who have very small lung nodules who are asymptomatic, so that we can put them on surveillance, and especially those patients who are more than 80 years of age. I just keep them on surveillance also, but at a short surveillance, at 2 or 3 monthly follow-up.
So I think we have one data that has shown that even active surveillance is an option, but that data was published in 2016 that I'll discuss in upcoming slides. So the point I was trying to make is that if the patient is not symptomatic, not very keen for treatment, then have an option of active surveillance. Obviously, we want the patient to understand the pros and cons. So this was a prospective phase 2 study. This was published before the IO and the newer TKI that we have. So this study was an active surveillance in metastatic RCC, and CT scans were done every 3 monthly in first year and then every 4 monthly. Primary endpoint was time to initiate the therapy. So the median age was around 67, and majority of the patients they were clear cell histology, and metastatic sites were both lung, lymph nodes, bone, and adrenal. So it was a small study in 42 patients who did not undergo during the surveillance period. The median acute change in tumor burden during surveillance was 1.3 centimeter. The median growth was 0.09 centimeter per month, and the OS was 38.6 months. The observation time was 14.9 months. So basically, it was more for favorable category of patients. You can see that the OS was 22.2 months. So I think in the present scenario, with the plethora of options we have, most of us are not comfortable doing observation as a treatment option. So Dr. Mohit, so how do you categorize the risk profile? What score do you use?
IMDC, because we are using the era of TKI, so we use IMDC criteria, that is for.
So do you think that IMDC score is good enough in the of IO plus IO? Because you said that you are planning IO plus IO, so you will be convinced using IMDC score for planning IO plus IO.
As far as I remember, that in the IO combination, that is NEVO-EP, they have taken the intermediate and poorest subset as a whole, and they have taken, as far as I remember, IMDC. That's what I remember. But anyway, correct me if I am wrong. Of course, IMDC is for TKI. I understand your point, but as far as I remember, what they have used, I think it is probably they have categorized probably with IMDC. That's what I remember.
Yeah, I think you are absolutely right. But the point that I was trying to make is that I think we need to develop more a better risk profile score in the present era of immunotherapy. The IMDC score was basically developed for TKI. So I think we have discussed some of the points. So Dr. Ankit, what would be your treatment option? The options that I have mentioned in the slide for this patient. Which IO will you use? Which TKI will you use?
So definitely, sir, I would use a IO with TKI because of the early separation of the graph and rapid response. But then, if considering this lady, this person who is 72 years old, I would like to prefer a TKI should be like exitinib, which is a shortest half-life, and with that either a pembrolizumab or a avelumab. But still, the category 1 indication is not there for avelumab, though I have used it avelumab, and it has a very less side effect. But still, by the book, I would go with the pembrolizumab with the exitinib.
So, Dr. Kripa, so would you agree with the Dr. Ankit, or do you have some other opinion?
I totally agree with Dr. Ankit. Here we are not seeing for the great responses rates like with Len plus pembro trial. Here it is fine with Axin plus pembrolizumab, relatively well tolerated compared to Len plus pembro.
Agree. So in what patients you will prefer the combination of pembro plus lenvatinib?
So if you see all the trials, like cross comparison clear trial with other, Len plus pembro is having a significant response rates. So here the disease burden is not so high. Whenever patient is having symptomatic disease with heavy disease burden, then I'll push for Len plus pembrolizumab combination than other combination, like than or Axin plus pembrolizumab.
Correct. So Dr. Davinder, so my question to you is that in what patients you will use IO-IO combination?
IO actually, Rajat, it's very easy to say, but it is slightly toxic. So I'll say in a patient who is slightly young, who doesn't have any other comorbidities and whom are quite convinced about this, in those patients only I'll use IO because a combination.
So suppose, sorry, suppose the ejection fraction is 25%. So in that patient, what would be your treatment of choice?
That is, in those patients, I have to discuss the family in totality. I have to explain them everything. Even though this double IO combination, the chance of deterioration is slightly there. So it all depends on how I discuss with the family, how I explain the pros and cons. And in those patients, I may even go for the single agent IO also.
Correct. So I think we don't have much experience with this combination and we are kind of skeptical. But I think this is a combination can be given to those patients who are not fit to take TKI. So this is a slide showing the major first-line trials. So the CLEAR trial was a combination of lenvatinib plus pembrolizumab. So you can see that the response rate was 71% and 16% patient had a complete response. The OS at 24, the OS at 24 months was 79.8%. PFS was 24 versus 9 months. And axitinib plus pembrolizumab, we have the highest data for this study, that is Keynote 426. The CR rate was slightly less, 9%, and the overall survival at 24 months was similar, around 74%. Then we have Nivo IPIT study Checkmate 214. In this also you can see that the overall response rate was 39% and the complete response rate was around 11%. And then we have Nivo plus cabozantinib. So this is definitely a very good option, especially for those patients that have a poor histological feature like sarcomatoid feature. So in this, the complete response rate was 9%. And then we have avelumab plus axitinib. So out of these, I think the most data that we have for highest response rate is probably lenvatinib plus pembrolizumab. So coming back to the patient, so this patient was not an affording patient, so she was started on sunitinib, and then she developed mucositis and grade 3 fatigue and hand-foot syndrome. So, Dr. Mohit, how would you manage this patient? So, what dose of sunitinib do you generally start to your patients? So, are you comfortable starting at 15 milligram or you start at a lower dose?
If performance status is okay, then I would like to start with the 50. But I don't want the 4 week on and 2 week off, but that's what is given to this patient. I would like to go for 2 week on and 1 week off patient. This patient was, I think, probably started on 4 week on and 2 week off. That's what is written in the previous slide. So yeah, 50 milligram is okay, but I think the age is, at this age, I think I would like to start with the lower dose compatibility. I think 76 was the age for the patient. So at this age, I think I would like to start with 37.5 and gradually build up to 50, 2 week on, 1 week off if the patient tolerates.
Right. So I think, yeah, so I think no one uses that 4 weeks on, 2 weeks of regimen, especially in an elderly lady. So Dr. Kripa, would you like to add something or differ from the opinion of Dr. Mohit?
I totally agree with Dr. Mohit, sir. I would be comfortable to start with 37.5, not 1570 plus male patient. So 37.5, 2 week on, 1 week off, I would prefer, sir, than 50 mg, 2 week on, 1 week off. I do start if it's tolerable, I will escalate than de-escalation.
So I think I also start with the lower dose, especially in elderly patients. So this patient had a good response to sunitinib, and after around 10 months of treatment, she had disappearance of the lung nodule, and that patient progressed after 10 months. So I'll come to the second line treatment option. So my question to Dr. Ankit, so suppose that you have started this patient on pembro plus axitinib, then how long would you continue pembrolizumab in this setting? Is there any data that you can stop? Because that is a problem that we face in RCC pembro people, they don't give any support also. So it becomes very costly. So what is the minimum duration and what is the ideal duration?
Progression. But I have some patients who are on single agent nivolumab on second line therapy, and that the patient start taking a lower dose or a gap of like 4 weeks to 6 weeks instead of 2 weekly regimen.
Okay, so Dr. Davinder, would you like to take that question? For how long do you continue IO therapy, and what is the dose of pembro do you use? Do you use 2 milligram per kg or 200 mg flat dose?
Rajat, I use 200 mg stat dose, and at least for me, at least 6 to 9 months of intensive treatment would give me much of a confidence, and after that, I can just depending on the finances, I can just increase the duration from 3 weeks. I can go up to 2 months. Even some patient I have given it 3 months into an also.
So I think the data is of 2 years, but very few of the patients can continue for up to 2 years. If the patient is maintaining response for 3 to 6 months, then we can consider probably increasing the frequency or stopping the IO drug. So, Dr. Ankit,
I would like to add one thing, sir. The data, like the follow-up data of the patient who attained CR or PR, like post 2 years, they stopped it. And they continue to maintain that response actually. Maximum 2 years, like whatever you said, rightly said, 2 years is fine actually. Max.
Correct. So I'll ask one question to you. So does your treatment plan, Kripa, changes according to the histology? Suppose this patient was papillary histology, then would your treatment plan differ?
Yeah, so papillary, like not a great response to IVO, but sunitinib, like there is a decent data is there, but IVO as clear, sir, it not respond. Definitely, I would push myself low to start with TK alone. I would like to see, sir.
And what would be your TKI of choice?
So currently, my experience with the sunitinib is like large, though cabozantinib is having a very decent data, but I'm comfortable using sunitinib as of now, sir.
So, Dr. Mohit, so again, the same question in clear cell versus non-clear histology. Would your treatment differ for non-clear histology? And if yes, then what would be your preferred treatment choice?
In the non-clear cell, I would like to use the TKI. And more data was, I think as of now, sunitinib, we have sufficient data. And I agree with the ma'am that Lenva can also be used. As far as I remember, in the hereditary leiomyomatous and RCC syndrome, I think we have some data of BAV plus Arlo as well, but that is probably in the second line, not in the first line. That's the additional thing in the papillary histology. But TKI of choice for first line, I think it is sunitinib.
So yes, I think in non-clear histology, we don't have much data, but IO plus TKI can be an option, but I think TKI alone can also be a good option. Cabozantinib have some data, sunitinib also have data in non-clear cell histology, so I think both can be offered.
I would like to add, sir. Sir, what the recommendations are if it is a sarcomatoid variant, the IO combination is preferred. If it is a papillary variant, either a TKI with the IO or TKI alone is preferred. But in the chromophobe pattern, definitely there is no role of IOs than TKI only.
Sarcomatoid cabozantinib plus nivolumab is also having a very
So there is IO, then cabo with there are 3 options.
What dose of cabo do you give with nivolumab?
Sir, actually, by book it is 60 mg, sir, but I have not seen any single patient tolerating that dose actually.
So anyone of you have given 60 milligram as a single agent also, because ultimately I have to decrease to 60 milligrams, so I started using 40 milligram only. So anyone can share their experience.
Yes, 40 is the people, like it's a maximum tolerated dose for us. It's never been 60 for even single patient to me.
Yeah.
I'm not sure about others' experience.
So this drug is relatively new to our market. So I think most of us now have adjusted to 40 milligrams. So anything different? So this coming back to the patient. So this patient progressed after 10 months of sunitinib. So how do you decide the next line treatment? So Dr. Davinder, so how do you decide the next second line treatment, and what would be your treatment of choice for this patient? Suppose if she was given pembrolizumab plus axitinib.
We are saying that patient has already received pembrolizumab and then he has received sunitinib also.
Okay. So why not lenvatinib plus everolimus or cabozantinib?
Yeah, in the third line, of course, because we are in the third line, there is scarcity of choices. So then it all depends how the finances, the toxicity profile of the patient which has reached the prior lines, and we can go for cabozantinib. There are often everolimus also, and of course, if the patient is still having some finances, we can retry the other IO also.
England.
Yeah, Kripa, please.
Yeah, sir. Len plus everolimus is a very decent option. Like everolimus, like 5 mg plus this. Low dose of lenvatinib. I have seen couple of patients who are respond really well in third line. So I think that's a very decent option to offer to patient. Cabozantinib, than that, like Len plus everolimus can be tolerated really well actually.
Yeah. So I think all are valid options, but the hazard ratio really favors lenva plus everolimus combination. But the doses that we use is actually much lower than what is recommended as you suggested. So all can be used, but probably lenva plus everolimus or any other of these drugs can be used in second line setting. So this is again a table showing the second line trials that we have.
I would like to add one
RCC
point. I would
Yeah.
like to add one point that the tolerance to the previous TKI is also important. If patient has tolerated the TKI well, then we can offer another TKI. But if patients have very poor tolerance to the previous TKI, then I think we should think about switching to nivolumab.
Yes, correct. So all these factors decide the second line treatment, the response to previous treatment, toxicity profile, duration, and the number of sites of meds. Obviously, personal factors like financial status. So these are the subsequent second line therapy that we can offer: cabozantinib, lenvatinib plus everolimus, nivolumab, axitinib. So now we are spoiled with options. So I think with this, I would like to thank all my panelists, and thank you, Dr. Asim and Dr. Tarachan, for giving me this chance. Thank you. Good
Thank
night.
you, sir. Thank you.
Thank you.
Thank you, sir.
Doctor.
Thank you.
Yeah, thank you, Dr. Rajit. And I would like